I think my topic was changed 5 days ago. The previous talk was, I think, was more exciting. But I think Dr. Bansi told me that you talk something about the forgotten electrolyte, that is the magnesium deficiency. And because physicians have not recognized the importance of magnesium, and in cardiometabolic disorders, which we are tackling day-to-day practice, what is the role of magnesium? The reason, I think it is quite crystal clear in this slide. But remember that what I am going to talk to you will be science and nothing more or less than science. It is an old molecule, and we are knowing about magnesium. We have in the literature, even in the 1888, there is some description about the magnesium. But 1932, there was some research on the magnesium. But still, I think it is not in focus. So magnesium is not just an electrolyte, it is linchpin of metabolic homeostasis. Very important, dhuri hai. So this is the linchpin of metabolic homeostasis. So whatever the insulin secretion is happening, insulin action and lipid metabolism somewhere, and not only here, I think in the body, at least at the 600 places where some enzymatic reaction is going on, magnesium is working and magnesium is needed. So it is a very, very important molecule. But why more buzz in 2026? Could be one reason that some pharma companies have come with the tablet. I'm not comment, but the emerging data suggests that magnesium deficiency does occur, and it is associated with an increased incidence of CVD, heart failure, serious cardiac arrhythmias, hypertension, and diabetes. So what remains? Retaining normal magnesium levels will prevent the onset of this disease. I think when I'm making such a statement, although this has been taken from a very important journal, that Endocrine Reviews 2023, but retaining normal, if you are retaining only the normal magnesium values, and that will prevent the onset of these diseases, it sometimes looks difficult to digest. That only magnesium, focusing only on magnesium will do something. But anyway, these days there are lots of research papers are coming up that when there is hypomagnesemia, it is related with somehow in the diabetes, in the heart, in the microvascular and macrovascular. Here it is a big busy slide, but just remember that serum magnesium represents only less than 1% of the total body magnesium. It can be reliably reflect true magnesium status. That is a very, very big challenge in clinical practice. So when you are measuring the magnesium from the serum magnesium you are ordering, so this may or may not reflect the true status of what is happening, because due to the body distribution of magnesium. So serum magnesium is always maintained in a fixed narrow range. You can see around 1.7 milligram to 2.4 milligram. That is the range it is being maintained. And this is due to increased bone resorption, intestinal absorption, renal reabsorption, intracellular magnesium depletion, so all are interacting. However, the serum magnesium cannot reflect the actual status of whole body magnesium levels. The serum magnesium levels is typically within the normal range, especially in the cases of chronic magnesium deficiency also, that is important. And intracellular magnesium deficiency can exist despite presentation of a normal status. So here is the crux of problem, that serum magnesium level could be normal, but still there is some problem, there is some intracellular magnesium deficiency. So thus serum magnesium is an unreliable marker of the total body magnesium and may detect deficiency only after functional impairment has occurred. So therefore the hypomagnesemia is a misnomer. Rather it should be taken as intracellular subclinical magnesium deficiency. So this part is very, very important, I think. This shows the prevalence of cardiometabolic risk factors among participants who have got many studies also published in the JAPI in the Indian context. the various etiological links between this hypomagnesemia and the type 2 diabetes. And there was a significant association between hypomagnesemia, dyslipidemia among patients with type 2 diabetes with magnesium. Lots of papers exist. But remember that the risk of hypomagnesemia, 2% is in the general population. If you measure it in the hospitalized patients, it is 10 to 20%. ICU, 50 to 60%. 30 to 80% in persons with alcoholism, and 25% in outpatient with the diabetes. This happens. This chart is from the Harrison latest edition, where we should be something should be aware about what are the causes of subclinical intracellular chronic latent magnesium deficiency. And you can see here if there is also a list, there is a long list, but if you just see here the vitamin D deficiency, if you are using the proton pump inhibitors, you are using diuretics like loop diuretics, then there is diabetes and treatment of vitamin D deficiency. So lots of things are and lots of causes are there. But this fact is crystal clear that the hypomagnesemia is 10-fold more common in type 2 diabetes. And this again has been taken from the quoting from the endocrine reviews that hypomagnesemia is rare in type 1 diabetes. This suggests that insulin resistance, not just the hyperglycemia, is the primary driver of disturbed magnesium homeostasis. So this is again an amazing fact. So these days, I think in the last decade, few papers are constantly pushing up that cardiometabolic diseases are associated with subclinical magnesium deficiency, and these are the diseases which I'll be showing. And the influence is again because you know there lots of things are happening if there is magnesium deficiency, how the whole chain is being disturbed. The modulation of the vascular smooth muscle tone and endothelial function that gets disturbed. Inhibition of neurotransmitter release and neuromuscular impulse conduction. Inhibition of calcium-dependent acetylcholine release from the motor end plate. And modulation of potassium movement in myocardial cells and increase the coronary artery vasodilation. Suppression of myocardial excitability and the prevention of cardiac arrhythmias, and prevention of atherosclerosis and decrease incidence of CVD and hypertension. So these are the few new things which are emerging. So there is a vicious circle of magnesium and insulin resistance, which I am showing here, how there is impaired insulin receptor tyrosine kinase activity leading to hypomagnesemia, then there is renal magnesium wasting, and then down-regulation of renal TRPM6 and hyperfiltration, and so there is this cycle is going on. So I think till now, importance of intracellular magnesium is quite clear to us that it is involved in many, many important functions of our body, and it is related to what is happening. If you decrease the intracellular magnesium inputs, you have got disturbed cardiac output, insulin secretion, release of neurotransmitters, inflammation and oxidative stress, vitamin D metabolism gets disturbed also, muscle contraction and relaxation, clotting regulation, lipid metabolism, vascular tone, and calcium homeostasis all gets disturbed if there is intracellular magnesium deficiency. So this part is very important. And then there is diabetic kidney, waste magnesium. There is lots of chain, I'm not going to tell you in detail, but there is diabetic kidney which lots of our patients have by TRMP6 downregulation. There is hyperfiltration, and these things lead to kidney wasting of the magnesium. And sometimes we also get the secondary contributors to magnesium deficiency, like if you are not taking the proper diet, which is rich in the magnesium, if your microbiota is disturbed, and many medications also like PPIs, diuretics, they are associated with hypomagnesemia, but explain less than 10% of variance in type 2 diabetes. Sometimes also the metformin may downregulate the TRMP6 in the colon, kidney through clinical impact is variable. So these are things how we are getting the secondary deficiency. So ultimately what is happening? If there is a constant hypomagnesemia, you have a strong prospective association, the direct link with the heart failure, diabetic nephropathy, diabetic retinopathy, and food complications. And category B is the indirect and the mixed association with the stroke, acute MI, coronary artery disease, peripheral artery disease, likely mediated by hypertension, lipids, and insulin release, and so many things here. And how this microvascular deep dive is with the heart failure, you can see here that the hypomagnesemia triggers cardiac fibrosis and hypertrophy. So lots of papers are again there. And I think electrolyte remodeling is an ion channels where the magnesium is needed. And if there is deficiency, there is cellular depolarization, prolonged QT interval, and repolarization instability, intracellular calcium overload leading to triggered activity. So these things are happening. If you think about the microvascular complication like retinopathy and nephropathy, there is inverse association between the magnesium and the diabetic retinopathy. In the same way, in the kidney, if there is low magnesium, that predicts the rapid decline in the eGFR. What is the mechanism? It is calcification. Low magnesium promotes phosphate-induced vascular calcification, increasing the arterial stiffness. I think this part is very, very strongly correlated. So there is mitochondrial dysfunction and oxidative stress because magnesium is needed there. So the ATP link and the outcome is that all such radicals, they uncouple the E and nitric oxide and turning a protective enzyme into a damaging one. So here is the role, and then there is endothelial dysfunction, inflammation, lots of signaling, vascular tone, everything I showed you, and there is a potential pathway of hypomagnesemia with the microvascular diseases. This I'm not going to say you detail, but lots of literature is there. And so I told you the consequences of hypomagnesemia. So important point to understand it here that there is subclinical intracellular chronic latent magnesium deficiency, and this balance in the serum magnesium levels remain within the lower end of reference range here, and sometimes that looks like that, oh, it is apparently normal magnesium status, although despite there is underlying deficiency. So clinical symptoms are extremely hard to diagnose since they are generally non-specific and overlap with the various other diseases. So this point is important. So it is often gets unrecognized, undetected due to lack of simple, rapid, accurate test. Traditional cutoff I told you that is, I showed you, and even individual with apparently normal serum magnesium may be magnesium deficient. So these are the few things which we should be aware, how the subclinical magnesium deficiency in cardiometabolic disorders. Now, if you ask me what are the clinical evidence that you are telling or supporting the role of magnesium in cardiometabolic disorders, so there are lots of papers are there. You can see all the new papers. This paper of 2025 again shows that magnesium supplementation significantly reduces so many parameters. In the same way, there is lots of papers here you can see here. Even the fasting, HbA1c, systolic blood pressure, even the diastolic blood pressure, less 2.7 mmHg, only due to magnesium they have correlated. Systemic reviews and meta-analysis of the 25 RCTs that also says that magnesium may enhance insulin secretion from pancreatic beta cells and improve key metabolic biomarkers. So these are few things are here. And again, the new RCT there with 38 RCTs. Again, shows here that magnesium, if you are taking, it decreases the systolic BP and the diastolic BP. So again, here is evidence. Magnesium significantly lowered BP in individuals with hypertension and hypomagnesemia, especially those on antihypertensive medication. So magnesium may enhance BP control through vascular and renal mechanisms, and I showed you. And this is a new, again, paper showing the highest levels of circulating magnesium compared with the lowest level were linked with significant 35% decrease odds of hypertension. Even the preventive roles has been shown. You can see here. Umbrella meta-analysis showing the same thing. So these are all many research papers are there. You can see they are cross-sectional, they are RCT, systemic reviews, they are RCTs, and the message is coming the same. That magnesium supplementation significantly improved systolic blood pressure, diastolic blood pressure, interleukin 6. So this is one thing, that daily supplementation of magnesium could be 300 to 500 milligram. And what are the, now the last part is, what are the clinical protocols for magnesium replacement? If you are convinced that there is a situation in our body and in our patients, of our hypertensive patients, our dyslipidemic patients, our diabetic patients, that there is, maybe the magnesium is normal, but still there could be some hypomagnesemia going on. What are the clinical protocols? So biological baseline, you can see that this is the recommended daily allowance is in the men 420 milligram, the women 320 milligram. But I'm not much interested about telling you about the drugs. You see here, we have got the natural sources also of the magnesium. Legumes, beans, peach, nuts, seeds, whole unrefined grains. So why first that we are going to promote our patients to tell about that these things are very, very important, so that you will not will go in the hypomagnesemia. So this part is again important. Because if you are even giving some drugs, and this is a huge business, you remember. When I searched the net, in the USA, at least more than 19 salts of the magnesium they are selling. 19. Some glycinate or tartrate or whatever may be. But most of the magnesium which is available in market, you can see it absorbs only 33%, and rest are unabsorbed and excreted. Oral replacement is the standard for the asymptomatic patient. If using a sustained release preparation, this message comes. So we have got lots of oral formulation. Standard preparation provides 60 to 84 milligram of elemental magnesium per tablet. So the gap, there is a huge gap between the salt weight and the elemental load. You can see here. Whatever you are giving, not all they are absorbing. This part should be remembered also. And when you are going for intravenous, that is sometimes definitely you are using magnesium. Aluminum phosphide poisoning, I think now it is very emerged. And many arrhythmias recently on the very, I think last week there was a paper where they used that in the ICU patients, whether the prevention could be possible of the tachyarrhythmias by the magnesium. That the trial didn't show that it happened. It was a failed trial there. So you can have a patient assessment, then you can think sometimes of the oral replacement therapy. But I will still say that diet and oral could be the best with the green vegetables. They are a huge source of almond nuts. It is a very, very good source of the magnesium. IV protocols we are not discussing here. There are some safety and toxicity issues also. And now the last part is that role of magnesium and vitamin D is because they are showing that if you are using both in the same tablet, it is more effective in increasing serum 25 OHD concentration in the vitamin D alone. So these things are coming up. And these are the salts which is now available in the market, a combination of magnesium glycine complex, amino chelate with vitamin D3. And they claim, or they say, that improves the fasting blood glucose, HbA1c, replete magnesium in long-term metformin, and supports maintenance of optimal vitamin D levels and improves blood pressure when added to primary therapy. So now I'm not going to give you any conclusion. Science is there, definitely. Magnesium is important. Magnesium deficiency is not a myth. It is a reality. But whether we are going advocating as a blanket, a combination of magnesium glycine complex with vitamin D3, I will tell that you take your own decision, because there is a challenge in the gaps in the therapeutic application. There are hard endpoint gaps. The biologic points are there. Even the SGL2 interaction is there. That's not the primary driver of the cardioprotection, magnesium. This canvas trial showed that SGL2 inhibits mostly increase the magnesium, and so canvas trial analysis suggests this is not the primary driver of their cardioprotection which you get. Sometimes they are saying. So concluding, this is from the endocrine practice itself. They say that the hypomagnesemia independently contributes to the development of atrial fibrillation, heart failure, and microvascular disease. Magnesium is involved in the several molecular mechanisms. The potential protective effect of magnesium on development of microvascular complications is largely explained by biochemical pathways that are activated upon hyperglycemia. And magnesium supplementation in people with type 2 diabetes has favorable effects on blood pressure, lipid levels, and endothelial dysfunction. Long-term magnesium supplementation studies are needed to determine whether the increasing serum plasma magnesium levels can improve cardiometabolic outfunctions. I think this has been beautifully summarized here. Routine visit, screen, normal, continue on when to do. But these are some evidence that this evidence is crystal clear. This is the science. So clinical implement path ahead. So you screen, interpret yourself, think mechanistically, and use magnesium as adjunct therapy. Where do you you are convinced that it should be there. Then the dose is 300 to 400 milligram per day. Then you should monitor and then integrate into routine care. This is some concept which is emerging very fast. So last slide is the executive summary of role of hypomagnesemia with the independent risk factor, molecular mechanisms, microvascular protection, clinical intervention, and the evidence gap is still huge. Remember, in spite of this talk, I will say that the evidence gap of regular magnesium supplementation is a huge gap. Thank you very much. Thank you.